My presentation today is approach to neonatal sepsis, and I understand most of us listening are more of, let's say, microbiologist and pathologist. So I'll try to do as much justice to this presentation, being towards the laboratory. But again, me being a clinician, please pardon me for being a clinician in the talk too. So let's see approach to neonatal sepsis. And we know that the neonatal sepsis can be early onset neonatal sepsis and late onset neonatal sepsis. Typically, there is no defined definition when you call it an early or late. Typically, early is less than 3 days, but typically most of the people will say up to 7 days will be considered as early, because typically the sign and symptoms present early in these babies, almost like 6 hours. And they are called this sepsis is caused by intrapartum infection. Late onset, 3 to 7 days. And today we are going to concentrate on early onset sepsis, and that affects the babies in-house. And please feel free to ask about the questions about nosocomial infections, DIC, how we manage, and all those kind of things once the child is critically sick. Today, my focus is how to identify babies who are at risk of infection by laboratory, and which babies to treat when we call that sepsis is ruled out, when we rule the sepsis in, and things like that. And newborns who have gone home may have community-acquired infections, and pathogens might be different. And most of the time, our pediatric colleagues have more experience with those neonates, because we as a neonatologist typically do not take care of those babies who have already gone home. Because in neonatal, we cannot readmit them back, because neonatal units are considered more like a sterile environment. And in US, you cannot readmit the babies back to NICU. And I know at MEMC, we actually had a NICU like that, which was separate from the regular NICU where we were admitting these babies. And with early discharge, especially in the United States, the baby are getting discharged at 24 hours and sometimes 48 hours. And these newborns do tend to show up in emergency room with early neonatal sepsis. And in this, the GBS is leading the way. So early onset sepsis, again, as I said, the definition, it's a major cause of mortality and morbidity. And almost 5 to 20% of the neonates die from early onset sepsis. And many survivors of confirmed sepsis have major sequelae. So it's a serious disease. It's really a serious disease. And even dying of one newborn is too much. That's what the message should be. And that's why you will see that we keep trying. Even though it is a low incidence disease, we try our best to decrease that incidence further. Early gestational age is significantly related to higher incidence of sepsis. Usually, but not always, it is bacterial. And presentation of systemic infections may be extremely variable and is very non-specific. Rule out sepsis is the most common discharge diagnosis in newborn, with variable treatment duration, and 48-hour being the most common. And just observation of these infants is also not uncommon. See, these are the common signs we all know. I don't want to go through the whole of this thing. The only thing I will say, all newborns or most of the newborn will present with the combination of these symptoms for anything. Anything is happening to them, they'll present with these symptoms. So you have to be careful as a clinician to figure out which baby is infected and which is not. And it is not uncommon in neonatology, actually. So whenever we have these symptoms, to have a rule out sepsis and to put the babies on antibiotics till we are sure it is or it is not the infection. So common organisms, simple, straightforward slide. And most of the time they are bacterial, and the prevalence or the incidence may have changed, but the microbial causes has not changed. If you see, the GBS is still 40 to 45%, E. coli, Staph aureus, other gram-positive like Strep viridans, Enterococci, very less common in early. Late, much more. Listeria is worth a mention because it is very difficult to treat. It is transmitted through placenta, And it's not uncommon to actually have infections with listeria, especially even in the United States. You'll be surprised. We see people who come from farms, have used unpasteurized milk and things like that. And I have personally seen a couple of patients with the listeria, and the treatment had to be really prolonged. And the other viruses, which we are not interested today. When it comes to pathogenesis and epidemiology, the most infections, as I said, are acquired intrapartum, and they are all ascending infections. When we have rupture of membrane or prolonged rupture of membrane before or during labor, we cause infection of the amniotic fluid called chorioamnionitis, which is actually a major risk factor of infection in these babies. And you will be surprised that the babies who are born preterm, even though the mother may not have real clinical chorio, 14 to 28% of these women will have either histological chorio or clinical chorio. And only 1% of the babies, or mothers actually rather, sorry, at term with intact membrane will have a chorio. So you can understand the difference. Whenever you are talking about preterm infant in neonatology, sepsis goes through the roof, and we just do not take chances. And there are a lot of times these babies are on antibiotics, and smallest of the baby can even have up to 3 to 4 episodes of infections. The problem with GBS though, however, most of the time you need rupture of membrane, but the problem with GBS actually is it can actually go up through occult tears. So that's why you don't have to have a florid rupture of membrane and prolonged rupture of membrane for the GBS to have high attack rate. And especially if we have premature prolonged rupture of membrane, the attack rate from GBS, it can be up to 33 to 50%. That's a lot of babies can get infected. This is, however, without intrapartum prophylaxis. And I'll allude to what is intrapartum prophylaxis is, and that is routinely actually practiced in the United States. And please pardon my ignorance if I do not know if it is practiced in India or not, because when I did my post-graduation there, the GBS protocols and all those things were not in place. Because when we have the infected amniotic fluid, we know when the babies are inside, they either inhale or digest the infected amniotic fluid. That's why it is not uncommon that pneumonia is the most common presentation in these babies. The preterm babies and low birth weight babies have major risk factors associated for early onset sepsis. As again, I said, listeria is worth mentioning here, even though it is less common, but it is difficult to treat. Incidence and the morbidity. And again, I'm going to allude to that IAP, which is intrapartum antibiotic prophylaxis for strep or GBS. We used to have incidence of almost 3 to 4 cases per 1,000 live births. Since the IAP has been started, it has dropped down significantly to 0.5 in term infants. However, kind of preterm, or we call them late preterm infants from 34 weeks to 37 weeks, that can be 1 per 1,000. It doesn't seem like it is too much, but it is double the incidence into from the term infants. Cultured confirmed cases of meningitis are even much lower. They are up to 100 times less. They are 1 to 2 per 100,000 or per lakh. So you can understand the chances of meningitis are pretty low in newborns. And the reason I say it, because when we come to CSF, which baby should get CSF, it becomes important to understand that. And again, when I was doing my residency, even back home and here, the LP was very common. Almost any baby who walked through the door of those special care nurseries were getting lumbar punctures. However, those lumbar punctures have dropped significantly. We do not do nearly as much lumbar punctures as we used to do before. Mortality is 2 to 3% in more than 35 weeks infant with confirmed sepsis. Less than 35 weeks, it can be much higher. So what clinical challenge we have as a clinician when it comes to sepsis, early onset sepsis, late onset sepsis, either one, is to identify the neonates who have high likelihood of sepsis. Which baby should get laboratory work and which baby should get treated. And the other thing is, how long do we need to treat them? That's why you will find that surprising that in neonatal, rule out sepsis is the commonest diagnosis. So we have a baby where we have rule out sepsis. After that, we will do their labs and clinical scenarios and risk factors and label them. Either we have ruled the sepsis out, then we call it sepsis ruled out, or probable sepsis, in which it is culture is negative. However, the baby had clinical presentation and laboratory findings which were strongly suggestive of infection. In those situations, we assume them to be infection and treat them as if they had infections. And I'll allude to why the blood cultures can be negative and things like that. And the proven sepsis is obviously simple, culture positive, proven sepsis, and you treat accordingly. No strategy so far has been able to identify all those infants and also at the same time avoid unnecessary treatment of the babies who do not need treatment. But the best we can do is find or identify the risk factors, go by their clinical scenarios, and make sure we do not even miss one infant dying of sepsis. That is the whole purpose. That's why we tend to treat much more babies who may potentially don't have to be treated, just because to prevent one baby who may have infection. So the risk assessment of sepsis is typically based on risk factors at presentation or clinical presentation, and it is supplemented by the screening labs. So clinical scenario, I already told those. So now the question is, when the baby is born, you are as a clinician, you are called as a pediatrician or a neonatologist, and you're trying to see if this baby will need antibiotic or should I do anything, or this baby can stay in regular nursery and we don't have to do anything. In that one, before we go to the delivery, if possible, not always possible, we're trying to assess the intrapartum risk factors for infection. And once we found out that these babies have intrapartum risk factors, then we run some labs. If the baby comes out and baby is symptomatic, that's no-brainer in a way. When we have symptoms, we know that this baby might have infections, but if they have symptoms in addition to risk factors, we know the chance of sepsis keep creeping up with each and every additional risk factors. And those are the babies end up getting treated with the antibiotics. So what are those risk factors? Chorioamnitis is the most important risk factors, and we can always kind of argue with the definition, especially from neonatal standpoint, because we may not know if our OB colleagues have diagnosed them in chorio or not. But for practical purposes for us, any temperature higher than 38 or 100.4 in the mother is enough to make a diagnosis of chorioamnitis. And these babies, after laboratory evaluation, need antibiotics at least for 48 hours till we make sure infection is not there. And the reason is because it increases the chance of infection tremendously. Other one, GBS colonization with inadequate intrapartum antibiotic prophylaxis. That means if the mother was GBS positive and we did not give antibiotics, those are the babies at high risk of developing sepsis, and they will need some kind of evaluation, either antibiotic or not. We will kind of discuss that a little later. The recommendation generally are sepsis workup with or without antibiotics, as I said, and sometimes just observation. As I alluded to, symptomatic versus healthy appearing infant. Symptomatic, that's not a problem. But the problem is sometimes the symptomatic, we saw all the symptoms. Some of these symptoms are just normal transition. Because the baby is born, he has a little respiratory distress, little fluid in the lung, and they'll get better in 6 hours. So if the respiratory distress or these transient symptoms can be attributed to non-infectious cause, then we potentially can observe these babies and don't have to put them antibiotics. This is when there are no other risk factors dictating antibiotics. Means No risk factors. Baby came out for maternal indication, has little bit of respiratory distress, starting to get better, then you probably can just watch the baby. The other thing is, and I remember from my residency days, sometimes the blood sugar was considered, or if the low blood sugar, then it should be considered as sepsis first. But just isolated blood sugar with no other risk factors and everything is not an isolated risk factor for sepsis. So just low sugar should not prompt us, if everything else is fine, not prompt us to do all those blood tests and put the baby on antibiotics and things like that. And we should try and figure out why the blood sugar is low. Either it's a low birth weight, preterm, small for gestational age, IUGR, infant of diabetic mother, or something else. Clinically symptomatic babies, again, I almost alluded to everything in this slide, but you will say most of the babies with early onset sepsis will have some kind of abnormal signs in first 24 hours, and most of them within first 6 hours of their birth. However, sometimes they will have those non-infectious reasons, let's say respiratory distress, that will resolve, and because if they have infection, they might have redevelopment of or kind of deterioration in their clinical scenario. Then the sepsis becomes more likely. Always be worried if the baby is less than 37 weeks. Any preterm infant, and especially less than 35 weeks, is a problem. More premature the babies are, the chance of infections are high. They cannot fight these infections, and we should be putting them on antibiotics and then ruling the sepsis out with the labs and everything. The problem is, what do you do when we have an asymptomatic infant? And especially, let's say we have a preterm infant which is asymptomatic. So this scenario is probably most difficult to deal with, and obviously the assessment is done with the risk factors and then labs. Let's say the infant is 35 weeks or 37 weeks. More recent guidelines, just like a year ago, they came out. That was management of newborn born at 35 weeks and above with suspected or proven early onset bacterial sepsis. They kind of divided these guidelines before 35, less than 35 weeks and more than 35 weeks. But any baby less than 37 weeks, be careful. If they have chorioamnionitis, premature rupture membrane, more than 18 hours, and they did not get adequate prophylaxis during the labor for GBS, then they all need sepsis workup and treatment if they are preterm. And in the next slide, you will see if they are not preterm, they need treatment if they have chorio. But if they only have premature rupture or inadequate prophylaxis, it is okay to the partial sepsis workup, and based on those values, you decide if they need treatment or not. Obviously, if they have, if in this scenario, you do a baby comes out, let's say baby is 36 weeks, the water was broken for more than 18 hours, mother does not have any fever, the GBS was negative, or GBS was, let's say, unknown or positive, and mother did not get antibiotic dose before 4 hours before the delivery. So everything kinds of meets the criteria. In this situation, you do CBC, CRP, blood culture, put the baby on antibiotics, and follow these labs, which we'll discuss later how we do and why all those things are needed, and then decide about the culture duration, the treatment duration. If the blood culture is positive, no brainer, you treat like sepsis. If blood culture is negative, but the laboratory is significantly abnormal, you still will assume it to be sepsis and treat such. But if the blood culture is negative, labs are normal, the baby is looking well clinically, just stop the antibiotic in 48 hours, baby goes home. Again, if the blood culture is negative, labs are significantly abnormal, consider giving the antibiotic for longer duration. Asymptomatic infant, in this one, this is for term infant. In the term infant who is more than 35 weeks or more than 37 weeks, if they chorio, they need sepsis workup and treatment. If they don't have choreo, they just need lab, which can be just CBC and CRP. And if they are abnormal, then you do blood culture and put them on antibiotics. Otherwise, those babies can just be watched and do not need any other kind of treatment. So, and we'll again, obviously, we will go over which labs, because I think those are important to understand what is the importance of these labs, what they contribute in our decision making, because these labs are just an ancillary way to understand what might be going on, and we do not treat labs. I'm sure all of us have heard that during our residencies and fellowship, oh, do not treat lab, treat your patient. And that's what we will try to understand, how much value we put on that sepsis workup. So the lab assessment is very simple: blood count, CRP, blood culture, urine culture, and CSF. So this is a little busy slide because I did not want to make 3 or 4 slides. And so when it comes to blood count has very limited value when it comes to ruling sepsis in or out. So the white count, IT ratio, absolute neutrophil count, or ANC, are commonly used to assess the risk of early onset. Neutropenia may be a better predictor than elevated counts. And even then, that is not really, has a great positive predictive value, and you will see a little bit lower. The IT ratio, which is also called immature to total, not immature to neutrophil only, mature, it is total. That means when you're calculating IT ratio, it is immature, which is band count, and in that band count, you actually have to incorporate metamyelocyte, because you will sometimes you'll see in newborn CBCs the band count, and then you will see metamyelocyte. So you add both of them, which are immature, and divide it with total neutrophil. Total neutrophil is mature neutrophil plus band count plus metamyelocyte. That's how you get that number. The other one, absolute neutrophil count, that is just number of neutrophils out of total WBC count. And they may have some significance, but not higher significance. It is the lower or low ANC or neutropenia, which may predict infection a little bit more than the higher numbers. IT ratio has been the best. Let me just rephrase it, I didn't read it right. IT ratio has the best sensitivity of any neutrophil indicator. A single determination of IT ratio has a very poor positive predictive value, only 20%. That means if we have a sepsis, it will be only 20% time the positive test will be because of sepsis. 80% of the time, that is because of some other reason. So that's what positive predictive value means. That means we have other reasons for them being abnormal. The normal IT ratio or the cutoff is taken as 0.2. Sometimes if you go into a little bit detail and read those papers, then you will see the 90th percentile in term infant is 0.27. But for practical purposes, 0.2 of IT ratio is taken as significant. So as I said, the positive predictive value is between 20 to 25%. That means you have more of the other reasons for the test being positive than not. However, it has a very high negative predictive value. Means if it is negative, then the chance of infection are less. That means 99% of the time, if there was no sepsis, the IT ratio was normal. And however, though, when we are talking about getting abnormal counts, it takes 6 to 12 hours for it to become abnormal. So that means if we do CBC or the other one which will be coming out, CRP, right at birth, that probably is not sensitive enough or does not contribute much. That's why you have to repeat a serial, a CRP and a CBC to see how much change it has, because it needs time to change. So if you do it right at birth, it may not show. So many times, do your blood culture, decide about starting the treatment, and do your CBC CRP at 6 hours to 8 hours of age. But many times clinically it is not possible. Many times because we are poking the baby, what we will do, we'll do CBC, CRP, blood culture right at birth and repeat the next day. Next day means because the baby is born even in the night, then it will give anywhere between 6 hours to 12 to 20 hours. 20 hours duration and giving a chance for the ANC and CRP to change. So we initially, when these reference values came for IT ratio, ANC, that was from 1976 actually. It was Monroe et al. Who had that paper where we had these references range, and that is practically used still. However, there are a couple of other papers which kind of changed those reference values. And there was one paper actually which compared the Monroe's, what should I call them, ranges to the new ranges, and they thought the Monroe's ranges were more sensitive because they were lower values. If they are lower values, they obviously will pick more babies with their sepsis, but their specificity was not very good. So bringing those values down, it did improve sensitivity, didn't improve the specificity. Means we were catching babies with more infection. We were having less babies left out, but I think we probably were treating more babies if we go just by blood count. But most of the time, as I said, the blood count is the least sensitive one. So we don't really even pay attention to blood count, I'll be very honest, unless it is combined with the CRP and it is both are abnormal, then we are more excited, if that is even a word. So in Monroe, the lower ANC at birth was 1800 and at 12 hours was 7800. The other guys, they had the limit higher. Say like at birth, it was more like 3500 and 6 to 8 hours, it was 7500. And according to them, the peak, and if you see the peak of when they kind of plotted, it went up like this and came down. Went up like this, came down. So it started here in 6 to 8 hours, peaked, and then started to come down in 72 hours. It was normal and then stayed normal. In the Mr. Schmutz and et al., they actually thought that the peak occurred a little bit later, like more like towards 12 hours. So smaller changes, but again, I do not know clinically how much significance it really has. And obviously, if we have a baby, we are strongly suspecting infection, these values may be helpful, but these values are very helpful in ruling sepsis out than ruling sepsis in. That is more important. So it cannot really rule sepsis in, even when they are positive, only 20% their positive predictive value. The other thing of note was that the later study which increased the range was done at high altitude. And high altitude has been shown to increase your WBC count. So we do not know if that increase in their reference values were just because it was high altitude, because the Monroe study was done at 500 above sea level, that one was done at 4,800 at sea level. So I don't know how much significant that is. But again, for argument's sake, we can always argue. I think even the 1976 ranges are still good for us to follow. And those ranges changes were essentially only for A and C. The IT ratio and total band count or absolute band count numbers, they were not very different. The other one is the CRP. And I know CRP has more questions, and these are, we all know, this is an acute phase reactant. There have been other like interleukin 6, interleukin 8, procalcitonin, and all those things have been studied. Procalcitonin is the other one which has been studied more extensively compared to the other. However, in my clinical experience, in neonatology at least, we do not use much procalcitonin. That does not mean many of the other centers may not be using. The other thing is in our ER, I know they do use procalcitonin for a little bit older children and adults. But I have not used procalcitonin as such for following the sepsis or deciding the duration of the treatment. So CRP is the most common inflammatory marker used. It increases 6 to 8 hours. And again, level at birth poor sensitivity because it needs time for it to increase. So first one at birth, not much value. You should do it in 6 to 8 hours and repeat afterwards. So in actually one of the study which excluded the birth value at birth, means birth because we are expecting it to be, and typically IC values around 0.1, less than 0.1, very common. And more than 1 is supposed to be abnormal, which is milligram per deciliter. And I think sometimes in India we do use per liter. So you'll add 1 zero in the front, which is 10 milligram per liter. So for here we use 1 milligram per deciliter. So in that study, when they excluded the value at birth, 2 normal CRP determination, 8 to 24 hour birth, and then 24 hours later had a negative predictive value of close to 100% for proven sepsis. That means you have a normal CRP, 2 values around 24 hours apart, starting from 8 to 24 hours, you can be rest assured there is no infection. And if you combine that with normal CBC, then you can definitely be 100% sure there is no infection. So these are the tests which will help you to obviously rule out sepsis. And many times it has helped me to rule out, let's say, staph epi infection, if it is a contaminant or a real infection. And many times when the CBC and CRPs both are normal, we are very assured that it is not a real infection, it is just a contaminant. Again, same thing, positive predictive value, similar, around 20%. And the other thing is the CRP determination remains persistently normal. It is strong evidence that bacterial sepsis is unlikely, close to 100%, and antibiotics can safely be stopped. In my charts many times, when we have the other risk factors and stuff like that, I commonly write, not commonly, many times whenever I feel like that this can be a problem patient in a way, that because of normal CBC and CRP, and I typically definitely do 2 values and maybe even 3, that the positive predictive value is 100%. That's why sepsis is almost 100% ruled out. Again, the other question can be asked, because most of these studies are just abnormal CRP and normal CRP, and abnormal value, as we said, is 1 milligram per deciliter. Nobody really said how high is high. In my clinical practice, in one of the study, which was pretty old, I think it was almost 98, I think. In that one, they said CRP level more than 3, or maybe we can call that 30. The positive predictive value, again, same around 20%. But I have seen when I start touching 5 with some other positive risk factors, I kind of start calling it more like presumed sepsis and treat for 7 to 10 days. I had just one baby not very long ago, maybe just like a month ago. The CRP went to 10.8. And in this baby, I treated for 10 days. I actually did LP and everything, because LP, wherever high probability of infection, LP is kind of indicated. So whenever it is more than 5, I tend to do LP, especially if the risk factors are there, maternal fever, or let's say band counts are abnormal and all those kind of things are there, then I do tend to do lumbar puncture. The other thing I have noticed in my clinical practice, they say that the CRP peaks around 24 hours. I have seen that if you start antibiotics, the first CRP typically normal, 12 hours later or whatever it comes, because we just say do CRP in the morning, we don't calculate hours, they say, and they typically do in 5 a.m., which can be anywhere between 6 to even, let's say, 20 hours. And I've seen even starting with the antibiotic, they have real sepsis, the CRP will peak, it will start going up, and next day after 24 hours, it will be almost double. So in my experience, the peak is almost 48 hours. So the first increase or the second increase, I don't get bothered. As long as the baby is clinically doing well, I know for a fact then it will start coming down. And I've noticed the next 24 hours is almost 2/3 or 60%. And then I do not repeat when I start seeing the trend. I decide about the treatment for 10 days. Then I'll repeat after 3 or 4 days to make sure it is coming down. And 100% of the time I have seen CRP coming to less than 0.1, definitely less than 1. within 7 to 8 days of treatment. The blood cultures, we know all these things. Most of the time, minimum volume should be 1 ml because the babies can have lower CFUs, so 0.5 is not reliable. And many times, the mother too tend to get antibiotics. So that's why those antibiotics can decrease the rate of positive cultures. Two-side blood cultures, some center used to do it, nobody does it. Looks like 1 ml is enough to get if there is enough bacteremia. Urine culture in early onset sepsis is not required because definitely up to 3 days, and many of the people will agree up to 7 days. If a baby comes till 7 days with sepsis or fever or anything, there is no need to do a urine culture because typically it is not an isolated UTI. Typically it is a hematogenous spread, and even if you get a positive culture, it is part of the whole process, not needing sonogram and all those kind of things. Gastric aspirate has no value in diagnosing sepsis. The other common question is about CSF. In high-risk, healthy appearing infant, the likelihood of meningitis is very low. The baby is having non-infectious like delayed transition, stuff like that, meningitis very low. If the baby has positive blood culture, then we have chance of meningitis up to 38%. So in those situations, we have to do lumbar puncture. So you will see the indication for blood culture will be any infant with positive blood culture or clinical course or laboratory data strongly suspecting bacteremia, bacteremic sepsis, where we call it presumed sepsis, like CRP being more than 5, mother had fever, GBS was positive, and baby was having respiratory distress, requiring a little bit more of the supports and things like that. Sometimes baby can be very serious and going into DIC and all those kind of things. In those situations, obviously that baby is more critically sick. Then obviously you can do CSF, but do not delay the antibiotic treatment if we cannot do the lumbar puncture. Because lumbar puncture should not be done if we think baby is not hemodynamically stable. Because we may treat the baby or get our CSF, but we will kill the baby probably. And it is not uncommon to delay the lumbar puncture 3 days, 4 days. And then potential argument is, oh, we should have a lumbar puncture before blood culture. Absolutely. But sometimes we cannot delay the treatment because delaying the treatment is more detrimental than just deciding for the duration of the treatment. Because essentially the meningitis, what it does is, it just changes the duration of treatment from 7 to 10 days to 14 to 21 days. Most of the time. However, it might change the indices, protein and all those things. It can change the cell count and all those kind of things, but it is still not very, we can still kind of make a determination if the baby has meningitis or not. The other thing when I was reading through the literature I found interesting was, and again, when we were doing our MDs and all those things, and even now, and I do that, let's say we have a traumatic lumbar puncture, then we will say, oh, let's see the number of RBCs and the total WBC count and try to extrapolate how many RBCs per WBCs we have so that we can kind of extrapolate what WBCs are coming from the blood and what are actually there for because of meningitis. And if we don't want to go through that, we will typically do for one one WBC, 500 RBCs. So in one of the study, they say even if you don't do that, it's not going to change much of the treatment part of it, because it might increase the sensitivity a little bit, but in clinical terms, it may not be such significant. So even in traumatic, just going by total number of cells might be enough to make a diagnosis of presumed meningitis. Obviously, it's not very clear cut. It's very muggy diagnosis, there is no question. But again, we know as a clinician, when we cannot rule it out, we always side with the caution and probably treat the infant for 14 to 21 days. Treatment, I won't go too much into this thing, but MP and GENT, MP and cefotaxime. Sometimes some of the babies, let's say they had hypoxic ischemic encephalopathy, or they have some kind of kidney disease or something, then we probably don't want to give GENT. then we can use cefotaxime. Most of the places will do gent level if we have to treat longer. Typically, I do not do gent level if we are only treating for 48 to 72 hours. Some people will still do one level at least to prevent from, I guess, legal issues, just to say that the gent levels were fine. If let's say the baby has hearing impairment or something later on, I typically do not do for the short term. But people can argue if you, for the gent, you have to do levels, this and that, why don't we just put MP and Ceph? And I'm sure many of our pediatric colleagues and neonatologists know when they starting uses MP and Ceph, there was somehow increased resistance. And in one of the paper, actually, there was increased mortality. So it is essentially restricted when we are suspecting meningitis, because cefotaxime has a good penetration to CSF. Then cefotaxime is definitely a consideration for those kind of situation. And this treatment, we are only talking about early sepsis, early onset sepsis, because later on nosocomial and all those things, there the amphotericin came in, Josin with the gent comes in, nefacillin or Wank plus gent comes in, because there the organism scenarios are very different. And all those small babies, especially the babies who have PICC lines and all those kind of things, in that one, staph epi is number one. GBS is not number one in that situation. As we all know, as clinicians, ceftriaxone is contraindicated because highly protein bound and displaces bilirubin to increase the chances of kernicterus. I think I'm almost running out of time, but I'll quickly go through. I just have a few more slides. Is that okay, Neeraj?
Now we have to conclude only one or two slides. Because treatment part will not be relevant for people who are attending this program, because we are already running short of time.
So I'll just say about the GBS prophylaxis, because I know there are some microbiologists and pathologists there. So I do not know if we use, if you do GBS prophylaxis India, or we are doing quite commonly or not. The GBS is the major factor. In '96, they came out with the way to decrease and do the universal screening for the mothers. And they have been revised subsequently from 2002, 2010, and 2019. And with that one, the case, the incidence has gone down from almost 2 to 3 to only 0.23, which is a great achievement. That way, I won't read through this thing, but all the mothers get universally screened for GBS at 36 to 37 or 38 weeks. And anyone who is positive, they get either penicillin, ampicillin, or NSAF. If they are allergic, then Clinda and Vanco. And if they get it more than 4 hours, that is considered adequate intrapartum prophylaxis. If they do not get more than 4 hours of antibiotic in, then the baby needs to be screened and they get their labs and all those kind of things done. If they are more than 37 weeks and they do not have GBS known, in that case, we go by risk factors. And if they have rupture of membrane more than 18 hours, or they are preterm or maternal choreo, then they get intrapartum prophylaxis. So all these things is based on if they do not get it, they had intrapartum prophylaxis indicated and they did not get it, those are the babies we evaluate even if they are not symptomatic, and many of them get treated by the antibiotics.